everybody. Welcome to today's ACLP Virtual Journal Club session. Just as a reminder, we will be meeting kind of every other month and trying to focus on articles that are included in the ABPN's article-based pathway for maintenance of certification for CL psychiatry. So thank you to everybody who came to our last session a couple of months ago related to perinatal psychiatry. And this month, I'm very excited to introduce Dr. Parker Gregg, who will be talking to us about the CAST randomized clinical trial. So Dr. Gregg is a nephrologist, an investigator in the Clinical Effectiveness and Population Health Program at Michael E. DeBakey VA Medical Center, and is an assistant professor of medicine at Baylor College of Medicine in Houston. She's published over 30 articles, including multiple articles focused on the diagnosis and treatment of depression in individuals with chronic kidney disease. So today she will be talking about the CAST randomized clinical trial, which evaluated the efficacy of Sertraline for the management of depression in patients with chronic kidney disease who are not on dialysis. And so the way this will work is that Dr. Gregg will speak for about 20 minutes about the article. Please use the Q&A functionality in the webinar to ask questions. If anything comes up that would benefit from us stopping to have Dr. Gregg answer the question, I'll do that. But otherwise, we'll have about 10 minutes at the end to go through the questions and get some answers for everybody. So Dr. Gregg, welcome and take it away.
All right. Thank you so much for having me. And thank you all for coming. I'm looking forward to getting to tell you all about this clinical trial that I had the privilege of getting to be a part of. So just to begin, I have nothing to disclose. As some background, depressive symptoms are incredibly common among patients with chronic kidney disease. What I'm showing you here is a figure from a meta-analysis that was done in 2013, and I've picked out the studies that used an interview-based assessment rather than a self-report questionnaire to identify depressive symptoms. But among these studies, it showed that depressive symptoms are present in about 21.4% of people with chronic kidney disease, which is a lot, very, very high prevalence of depressive symptoms in this patient population. And in patients with CKD, depressive symptoms are associated with adverse outcomes. So here is a Kaplan-Meier curve showing that among people with non-dialysis CKD, having depressive symptoms was significantly associated with the composite outcome of death, dialysis initiation, or hospitalization. The problem is that we don't really have great data about how to treat depression in people with chronic kidney disease. Now, our patient population was largely excluded from a lot of the larger clinical trials of different antidepressant therapies for a lot of reasons, but it sort of leaves us, holding the bag about what to do to treat this in our patient population, which is what led my mentor, Susan Hedayati, to initiate the chronic kidney disease antidepressant Sertraline trial, which was published in JAMA in 2017, to look at the effect of Sertraline on depressive symptoms in patients with non-dialysis CKD compared to placebo. So in this study, the hypotheses were that in patients with non-dialysis CKD stages 3 to 5, short-term treatment of major depressive disorder with Sertraline compared to placebo, 1, will result in improvement in depressive symptom severity and quality of life, and 2, will be safe and well tolerated. The participants were recruited from 3 large medical centers in Dallas, Texas. They all had non-dialysis dependent CKD stages 3, 4, or 5. And they had to have depressive symptoms measured by the Quick Inventory of Depressive Symptomatology, which I'll hereafter refer to as the QIDS, using a previously validated score of greater than or equal to 11. And just a little bit of information about the QIDS so that you can interpret those numbers is that the score ranges from 0 to 27, with higher scores indicating worse depressive symptoms. So for this study, we would screen patients in clinic with CKD, identify people who are potentially eligible, and approach them to fill out the self-reported QIDS. If they had a score of greater than or equal to 11, we would invite them to come to a screening visit with us, where we would conduct more in-depth assessment of their depressive symptoms, identify other inclusion and exclusion criteria, and make sure that they were truly eligible for the trial. For people who were eligible for the trial, they would then enter a 1-week placebo run-in phase to identify people who either responded to placebo or who just didn't take the study drug. And the placebo run-in phase was a single blind phase. And then at the end of that run-in phase, they were then randomized to receive either sertraline or placebo for a total of 12 weeks in double-blind fashion. And then at the end of those 12 weeks, the drug was withdrawn and they went through a 6-week washout period to follow up their depressive symptoms. So some key inclusion and exclusion criteria include an age at least 21 years. They have to have CKD stages 3 to 5 and a clinician-rated QIDS at the screening visit of at least 11. And they had to have a confirmed unipolar major depressive episode using the Mini International Neuropsychiatric Interview, or the Mini, which is a tool based on DSM-4 criteria. Exclusion criteria included people who were receiving dialysis or who had received a kidney transplant. If we, on the Mini, identified individuals with bipolar disorder or psychosis, they were excluded from the study. Anyone with acute suicidal intent was excluded from the study. People with significant hepatic dysfunction, because that can be a safety concern with sertraline, were excluded. And then individuals who had ongoing use of other antidepressant medications were also excluded from the trial. So what we did was start participants on either sertraline or placebo at 50 milligrams per day. And I think it's really important to understand that in a lot of the other literature in patients with kidney disease, one of the major limitations is a lack of adequate dosing. So what we did was was a measurement-based care process where we dose escalated by 50 milligrams per day every 2 weeks up to a maximum tolerated dose of 200 milligrams per day, with frequently following up any side effects that they were having and intolerability issues. And then in the last 6 weeks of the trial, the dose was kept constant. The primary outcome was improvement in depressive symptoms as measured by the clinician-rated QIDS, or the QIDS-C, from baseline to 12 weeks. And secondary outcomes included a treatment response, which was defined as a 50% or greater decrease in QIDS-C from baseline, remission, which was a decrease in QIDS-C to a score of less than or equal to 5, quality of life as measured by the Kidney Disease Quality of Life Questionnaire, which is a very commonly used quality of life questionnaire in the kidney literature, and adverse events and tolerability. So just to make sure we're all on the same page about the overview of this study, the participants were individuals with CKD stages 3 to 5 and major depressive disorder. The intervention was sertraline at a maximum tolerated dose of up to 200 milligrams per day compared to matched placebo for a primary outcome of improvement in depressive symptoms. The statistical analysis was done using a modified intention to treat, which means that they had to have at least one QIDS-C assessment after randomization to be included in the primary analysis. And the QIDS-C scores were compared between the sertraline and placebo groups using a repeated measures mixed effects model, with the treatment group as the between participants factor and the slopes and random intercept as the within participants factors, with the baseline QIDS-C included as a covariate. So we approached more than 14,000 people with the QIDS, the self-reported QIDS, which we used as our pre-screening tool. And of those, about 1,000 of them fulfilled the criteria of having that self-reported QIDS score of 11 or higher. Of those, 736 were excluded, and the vast majority of this was because they didn't want to participate. For many of them, they didn't want to take another medicine, come to more visits. They just weren't interested. And then there were some who were discontinued for other eligibility reasons. So they either had initiated dialysis, or they had failed to meet criteria for major depressive disorder, things like that. So that left us with 261 people who initiated the single blind placebo run-in phase. And of those, 60 were excluded, primarily, again, because they just changed their mind and they didn't want to do the study, or because they didn't come back for randomization and weren't reachable to come back for randomization. But there were also some who experienced a placebo response and some who failed the run-in phase just because they didn't take the placebo, and so they were not randomized. So that left us with 201 individuals who were randomized, with 102 randomized to receive sertraline who received sertraline, and 99 who were randomized to and received placebo. Of those, we had some who were lost to follow-up or who discontinued the trial. And so that left us with 97 who were included in the primary analysis in the sertraline group and 96 in the placebo group. So I've not presented all the baseline characteristics here to save time, but there are a few key things I would like to point out. So in general, the baseline characteristics were similar between these groups. The participants were male predominant because one of the recruitment sites was a VA hospital. Participants were racially and ethnically diverse. Slightly under half the sample had CKD stage 3, about a third had CKD stage 4, and the remainder had CKD stage 5. And baseline depressive symptoms measured by the QIDS-C were similar between groups. To look at their comorbidities, about 60% had diabetes and about 32% had heart failure. Use of concomitant medications was similar between the two groups, and baseline creatinine was 3.2 in the sertraline group and 3.1 in the placebo group. Inflammatory biomarkers were also similar at baseline between the two groups. All right, so getting into some of the meat of this, let's look at the characteristics of treatment that were actually received in the two groups. So first, the median duration of treatment in days was 84 days in both groups with a between groups difference of 0. And of the two groups, almost 85% actually completed the full 12 weeks of the trial, which is a pretty striking retention rate to complete the full 12 weeks. The median drug dose at study exit was 150 milligrams per day in both groups, with a between groups difference of 0. And the percent of drug taken was 94% in the sertraline group and 96% in the placebo group. Again, not different between the two groups. Very few people were non-adherent based on pill count, just 3% in the sertraline group and 2% in the placebo group. Again, not significant between the two. This is the primary outcome, looking at the serial changes in the QIDS-C scores from baseline to week 12 of the study. So you can see that the severity of depressive symptoms decreased in both groups, particularly in the first 2 weeks of the study, but there was really no difference at all between the two groups in the improvement in depressive symptoms. Showing you this information a slightly different way, this is this numerical information that I just showed you in that previous figure. So what I'm showing you here is the QIDS-C score change from baseline to week 12. We also evaluated and presented in the primary paper the analysis in subgroups by CKD stage and by study site, but given that the results were similar in those subgroups, I'm just choosing to present here the entire study. But please know that those results were similar in the subgroups. So in any case, the QIDS-C improved by 4 points in both the sertraline and placebo group from baseline to week 12, with a between groups difference of 0.1, and that was not different between the two groups. Of the secondary outcomes, the treatment response, which was the 50% decrease in the QIDS, occurred in 32% of the sertraline group and 25% of the placebo group, but this did not reach significance either. And remission, meaning a QIDS-C of less than or equal to 5, occurred in about 15% of both groups. Now, I've selected a couple of additional secondary outcomes to show you. So the work and social adjustment scale improved in both groups as well, but was not different between the two groups. The Kidney Disease Quality of Life Survey presents a lot of different subscales, which I'm not presenting here to save on time, but I did want to show you the sleep subscale because that was one that did come out significant. So you can see here in the KDQOL, a higher score indicates a more favorable quality of life domain. So in the sertraline group, you had a sleep domain that improved by 12.5 points. And in the placebo group, it improved by 7.5 points. But the difference between those two was a 5-point difference with a 95% confidence interval of 0 to 12.5 and a p-value of 0.03. And then the KDQOL also presents a couple of physical and mental health composite scores, which I've included here just to show you that they basically didn't change from baseline to week 12 in either group, and this was not different between the two groups. So this is a plot showing you the QIDS-C scores from baseline to study exit in individual participants. So you can see that the sertraline group is shown in blue and the placebo group is shown in orange. Most individuals had an improvement in their depressive symptoms from baseline to week 12 during this study. There were a handful of people who had a worsening of their depressive symptoms or no change at all. But the improvement in depressive symptoms, you can see how long some of those lines are for those individuals who started the trial with higher depressive symptoms at baseline. So you see, in general, you might have a greater improvement in depressive symptoms for those who start the trial with worse depressive symptoms to begin with. And to touch on some adverse effects and tolerability, nobody died during the study period. There were a handful of people who started dialysis, but this was not different between the groups. There were also several people who were hospitalized for reasons other than dialysis initiation, but again, this was not different between the two groups. We specifically looked at bleeding episodes requiring blood transfusions or hospitalizations because patients with kidney disease are at risk for bleeding and clotting issues. And so this was, again, not different between the two groups. Despite the sort of questions of sertraline's effect on platelet aggregability. And there was one individual in the placebo group who developed acute suicidal intent. And there were about 3% in each group who discontinued the drug due to intolerance. So no difference in the serious adverse events in the trial between the two groups. But in terms of tolerability, there were a couple of things that are worth noting. So first of all, nausea, indigestion, and vomiting was very common in individuals on sertraline. This occurred in 22.7% of the sertraline group compared to 10.4% of the placebo group and was significantly different. And diarrhea was also more common among those on sertraline than placebo, 13.4% compared to 3.1%. Other tolerability, symptoms were not different between the two groups. So anorexia, increased appetite, insomnia or somnolence, decreased memory or confusion, incident hyponatremia, dizziness, syncope or fall, and anxiety, irritability, or agitation were all not different between the two groups. There are some strengths of this study that are worth noting. This is a racially and ethnically diverse sample. It was recruited from a VA, a county hospital, and a university hospital to increase the generalizability. And we really targeted making sure to get an adequate dose of SSRI to these patients to really see if this worked for them. And we had a very high retention rate in the trial. But there also are some important limitations to discuss, which include that we didn't assess longer term effects of sertraline in patients with CKD. I mean, I think as everyone here is well aware that when you start somebody on these medications, it's not just for a 12-week period of time. This trial does not answer questions about longer term efficacy or tolerability. We did not include patients on dialysis or with a kidney transplant, so it's not clear whether these results could be extrapolated to those populations. And even though we recruited from 3 very different hospital type settings, it was all from a single geographic area. So the bottom line is that among patients with non-dialysis CKD stages 3 to 5 and major depressive disorder, sertraline did not significantly improve depressive symptoms compared to placebo, but it did lead to more gastrointestinal side effects. And with that, I think I am right on time, and I will take any questions that you have for me.
Well, thank you so much. I'll give folks a couple minutes to start putting in questions. I guess for me, I feel like these kinds of negative studies are not uncommon, especially in patients with medical problems. If I think about like the heart failure literature, for example, folks with, in the MOOD-HF trial and the SAD-HART-CHF trial, both sertraline and escitalopram were not helpful in terms of that. And so it makes me wonder what was going on. Could this just be could these folks have a medical problem that, and their medical symptoms are not going to get better, and this is kind of a different thing than typical major depression. And so I wonder, in this study, did you guys look at all at kind of the types of symptoms that got better with sertraline treatment and those that didn't, or whether these folks had how many people had a history of depression before this, and how many people were kind of just screening in for the first time for depression?
Great question. So we have done several secondary analyses of this study. And one of the things that we've particularly looked into, because we share your question about whether depression associated with chronic medical comorbidities is a different entity. And so we've done a few papers looking at inflammatory biomarkers and whether underlying inflammation in patients with CKD might be generating these more somatic depressive symptoms, because a lot of our patients present with things like fatigue, and that's an overwhelming symptom for our patient population, that it's an overlap between depressive symptoms and symptoms of kidney disease. So we looked into inflammatory biomarkers, and we found in one study that baseline elevated high sensitivity C-reactive protein was associated with more favorable sertraline treatment response. But the evaluation that we did of the changes in inflammatory biomarkers over the course of the trial was less conclusive.
Okay. And so you looked at C-react, did you look at interleukins as well? I think you mentioned an interleukin at the beginning of this talk.
We did. The inflammatory biomarkers we included were albumin, prealbumin, high sensitivity C-reactive protein, and interleukin 6. So
Cool.
C-reactive protein was the one that really came out as showing some association with the outcomes.
So I guess in terms of kind of clinical implications of this, do you have a sense of, I guess, when you would think about treating folks with CKD with an antidepressant, or when not to treat them with an antidepressant, and how this kind of how this study kind of has contributed to that thought process?
I think that's a very important question, and I wouldn't say that there's like a hard and fast answer to it, but for me, a lot of it depends on the patient's preferences. If they are suffering, and this trial showing that on average this treatment does not work compared to placebo doesn't tell me that we never use it. It just tells me that you have to be careful when you use it, and think thoughtfully about when to use it. So if you have a patient who is engaged in care and who wants to try a medical therapy for depression, I think it is reasonable to do a time-limited trial of sertraline. We chose sertraline for this trial because it has the most favorable cardiovascular safety profile, and that's a big deal in patients with kidney disease. It's not to be taken lightly. So if you think about some of the more QT prolonging SSRIs, for example, citalopram and escitalopram are the ones that come to mind. You'd have to be pretty cautious using those in someone with kidney disease, and so there's a reason that sertraline was the drug of choice for this study. And I think, in my opinion, if I'm starting somebody on sertraline, I will probably see them pretty frequently, cautiously dose up titrate, and follow them closely for tolerability to make sure that they're not having particularly adverse GI effects. Mm-hmm. And, if they're not having efficacy after a period of a couple of months, then de-escalating treatment, not just sticking them on it forever, but actively de-escalating treatment for people for whom this is just not an effective intervention. So that's usually my approach for using medical therapy to treat depression in people with CKD. But there are other trials that have looked at cognitive behavioral therapy, for example, or things like physical activity, both of which are low risk and potentially effective to treat depression. So for patients who are willing and who have access to those things, they could also be very worth recommending as alternative interventions.
Mm-hmm. Cool. Got a couple of questions I wanted to bring up. Any recent research in patients who are receiving hemodialysis, I guess, in terms of treating depression?
Great question. So the biggest study about those patients was the ASCEND study that was published in the Annals of Internal Medicine That was a study that compared cognitive behavioral therapy to open label sertraline in patients who were on chronic hemodialysis. And unfortunately, because of the way that that trial was funded, there was actually no untreated control arm. And so it's hard to know how either of those would have stacked up compared to a true control. But what it showed was a marginal improvement in depressive symptoms that was slightly more favorable in those receiving sertraline than CBT. But similar to the CAST study, you saw an improvement in depressive symptoms in both arms concomitantly.
Great. One other question that came up was, did patients who were receiving sertraline versus placebo have a harder time coming off of the medication? Like, did the folks who were on sertraline, once you guys finished the 12 weeks and you had that kind of tapering period, did the folks on sertraline have withdrawal symptoms of some kind?
We did not identify any real signal for withdrawal symptoms. That's a wonderful question. And it's, again, something I think, particularly in the kidney population, without having data from larger clinical trials that initially tested these treatments, it's important to think about how drugs affect them. When we're talking about drug dosing in patients with kidney disease, I think we often have this reliance on thinking about their eGFR, right? So are they clearing drug? Yes, no, like to what degree are they clearing drug? But kidney disease affects people's pharmacokinetics in so many other ways. Protein binding, volume of distribution, absorption. There are all these different ways that kidney disease can affect a patient's pharmacokinetics and lead drug effects and adverse effects, really unpredictable in a lot of ways. And so my usual rule of thumb is to just be relatively cautious when I'm trying to dose someone. Start low and go slow, and dose up titrate based on how they're feeling, and monitoring for those effects. Because I think that that's really a key part of dosing any drug in patients with kidney disease, to be honest.
Mm-hmm. I think one thing that I think I kind of brought up, and I'm not sure if it was fully answered, but do you have a sense of whether the participants who were in the study had a history of depression before, or what percentage of them had a history of major depression, and how many of them were experiencing their first depressive episode at the start of the study?
Thank you for bringing that back up. I don't have a figure in mind, to be totally honest. The way that we included patients in the study was to exclude anybody who was at baseline already receiving treatment. So that excluded a lot of people who had prevalent major depressive disorder. But we didn't really, we were basing the inclusion in the study on the current experience of a unipolar major depressive episode. And so I don't really have that figure for you about whether there were overwhelmingly patients with incident depression versus prevalent.
Yeah. No, I think it's funny, right, because you guys, if they were on an antidepressant, they wouldn't have been eligible anyway, or receiving some kind of treatment. So that would be tough to get. I'm thinking back to the heart failure trials, and I think that, interestingly enough, those two negative trials, MOOD-HF and SAD-HEART-CHF, I think probably 75% of people, or something along those lines, actually were experiencing their first episode of depression when they did that, which again does make you wonder if this is kind of a separate clinical entity that would be different than regular depression, because I think our typical depression would have started much earlier in life than this time. All right, I think we are right kind of at the end of our time, so I want to be mindful of everybody's time. So first, I wanted to thank Dr. Gregg so much for kind of coming and talking to us about this. Thank you to everybody who kind of came to participate in this, and to those of you who kind of sent some questions. We will continue to do this every other month. Our next scheduled talk is by Dr. Scott Beach, who will be talking about QTC prolongation with psychiatric medications. So that will be happening in July. So keep your eyes peeled for emails about it. So thank you again. I hope everybody has a nice week. And thank you again to Dr. Gregg for being with us today. Okay, take care, everybody.